Please join me in welcoming Randy KOJIMA.
Hey, thanks, Sharon. Much appreciated. Hey, everybody. I'm so excited to be able to have this session with you and to talk a little bit about how we align Medmont and this super powerful software called Wave. I know most in the group will already use it, and but there may be some newbies or neophytes. So we're excited today to try to give you that connection between the two. How do we use Medmont to best support the Wave software? So this will be very concentrated on the topography side to make sure that we're doing all the right things before we send the data into this really, really powerful contact lens software. So let's begin. And the first question I might ask you is, how do we achieve this outcome, this optimal orthokeratology fit, this ideal lens to surface relationship? And I think it's true to say that orthokeratology lenses may be the most complex construction of lenses that we fit, certainly of corneal GP lenses. How do we get here? And another question is, how do we achieve real efficiency in practice? Because of course, if our first lens isn't correct and we have to refit, then that's a lot of extra chair time and visits. So how can we optimize this whole process of using both the topography and Wave together to be ultra efficient, accurate, and successful with the systems? Well, it all starts with the topography. The Wave software is, of course, a topography-derived system. So we take the maps and all those thousands of data points, we import it into the Wave software, and then we can use this powerful platform to build a lens. So it kind of stands to reason if the topography data going into Wave is poor, that's going to make it awful tough on you to be able to design a really highly accurate lens. And, when we think about orthokeratology lenses, they need to be microns away from the eye, not 20 microns as in a normal corneal GP or hundreds of microns as in a scleral. In an Ortho-K lens, it's literally just microns above the eye surface. So we need to get the topography right. Now, one of the things that we also need to consider is fitting by tier layer profile. And this might be one of the most powerful things that Wave allows us to do. We're less concentrated on what this looks like and far more concentrated on what this looks like. And that's the lens to surface relationship and the underlying tier layer between the two of them. So as you become an expert with a system like Wave, you really want to understand that tier layer profile. And how do we best get to the ideal tier layer profile? Of course, good quality topography is the key. Now, when we look at a particular map that we've taken, what tells you that this is a good topography? When you look at this map, would you say that this is an ideal capture? Is it the ideal interpretation of eye shape? Well, I don't know if it is exactly, but there are a few signs that will guide us. And one of those might be how smooth the map is. Notice how each contour is so well rounded, and from the steepest to the flattest, it follows this gradual rate of flattening. Now, I might concentrate on just one meridian, the horizontal here, where you see the white line. Then look at the power distribution across the cornea underneath this white line. Notice how smooth the topography is as you go from center to periphery. There's this very gradual change that happens. That's an awfully good sign that this is a good topography. I mean, this is a normal, healthy eye. We expect it to be very smooth in the way it transitions from its steepest to flattest points. When we go to the steep meridian, now we're running the white axis line to the vertical, and you see a similar story. boring. It's just this gradual, uninteresting change in curvature from center to periphery. So boring is really good when it comes to our topographies of the normal eye. We don't want to see a hot spot immediately next to a cold spot. We don't want to see the contours, let's say the red that has these angular points in them. That's kind of a good sign that there's something wrong with our capture. Maybe the tear film was poor. Maybe there's scarring on the surface that's hindering a quality reflection off the eye surface. Really, a normal, healthy cornea should show very gradual change from steepest to flattest. Now, how about here? When you look at this topography, are there signs that this is a good or bad topography? And clearly, the coverage is an issue. We're blocking the rings from getting to the superior cornea, and the lower lid is certainly blocking the rings on the inferior cornea. And there's other signs as well. So what are those other signs? Well, let's again go to the flat meridian of the eye. With the rural cornea, flat meridian is horizontal. And we see some humps and bumps in this cross section. So underneath this white line, you notice some asymmetry between the nasal and the temporal side, but also there's these steps in the surface, which that makes me kind of suspect. That could be real. It's possible that this eye has these sort of jumps or radical points of curvature change. But what really is a concern is down there on the lid. So let's go to the steep axis. Let's take our white line to the vertical. And I want you to follow how the cornea goes from steepest here, then a little bit flatter, then steeper, and then suddenly you hit this cliff. And you see that much better on the graph. Notice how the cornea has this rate of flattening, and then all of a sudden, wham, we just hit the drop-off point. That's a real questionable area, and it's most likely to be just false data from the ring distortion near the lid margin. Oftentimes you get the tear wedge down there that can distort our understanding of the underlying shape. So this is a very questionable topography. Now, if we were to force this map into the WAVE software and try to build a lens from it, I'm going to just try to model what you see. And across the horizontal meridian, remember, this is the flat meridian of the eye. This is where a rigid contact lens should be landing with all its weight and pressure. And it's really not, where we have tear layer all the way underneath that horizontal meridian. That just doesn't make sense. The flat meridian is where the vast majority of bearing is, landing is. But going to the vertical, where that hot spot is, notice how the system has to deal with that air at 6 o'clock that creates a high elevation, and it gives you this very bizarre pattern where the lens is landing at 6 o'clock right here and then landing just inside of the optic zone up here. It's just, this data is so poor that we really need to edit out those points. So these are the kind of things you want to look for before you send these maps into the WAVE software, so that when you construct, you're building the ideal parameters for the actual shape of the eye. Now, these kind of things can be helped. Now, certainly we have kids that have small fissures, and that can be a challenge to get them to open up wide. A few tricks that you can try are to pull down on the cheek. That's a way that you can open up the fissure. You can get that tear wedge off the lid margin. You can edit out these points here, and this is a very powerful thing because you get rid of the erroneous data before it goes into the WAVE software. So important things for us to do before we send data to the WAVE. And I can't emphasize enough to you how important it is to spend the time on these baseline topographies. You know, oftentimes you're pushed for time, but this is one where you really want to spend as much time, be exhaustive about this phase, because good data going into wave creates good data coming out of wave. Now, how do we achieve that perfect topography capture so that we do send good data into the software? Well, the goal, of course, is get the lids and lashes open as wide as possible. For Medmont users, it's a reflection-based Placido topographer. So we're reflecting these rings off the eye surface, and that's actually not off the tissue, it's off the tear film that's on top of the cornea, or on top of the epithelium. So what we want to do is get a perfect reflection, and the way to do that is to have even fluid layer, have the patient blink regularly. I have the patient take a blink every 4 seconds to ensure that we have good tear film quality. Put in artificial tear if the tear film breakup time is measured in, a second or milliseconds, but just blinking more often may be the trick that you need. Now, when you get your topography, we want to see lots of coverage. We want to see those contours smooth and well-rounded, and from steepest to flattest, it's a very gradual rate of change. So from the peak of the mountain down to sea level, there is this very slow and gradual slope, essentially, is what we expect to see in the normal eye. Of course, if it's a post-surgical eye, it's going to be a different story. Now, there's numerous capture options that you may be familiar with. Most topographer companies will teach you to capture along the visual axis, and Medmont is no different. For advanced software platforms like the Wave, you may be asked to do something called a geometric capture, and that's where we try to center the topography to the cornea, and we'll talk a little bit more about that. What I would highly recommend is, if you are using a single capture, like a geometric capture, so you're taking one photo, you would do multiple captures in that mode, meaning you're going to take multiple readings with the same fixation. That way you can determine, are we getting the same shape 4 times over? Is it reproducible? That's one of the things. And then the second thing is, do one of the maps show a slightly smaller fissure than the others? Or does one of the maps seem to have some erroneous data? So do we throw that one out and keep the best one, the one that has the most coverage, has the smoothest contours? Now, Medmont has a unique feature that allows you to take multiple different fixations, and it's called a composite map. This one is very useful to get a lot more peripheral corneal data, but the experts at Wave feel that the geometric capture is the best way to build an ortho K lens. So we'll focus a little bit on using that capture. Now, a visual axis capture is just simply asking the patient to look right down the axis of the instrument. And now what you want them to do is stay fixated on that central ring. Simple and straightforward. What that gives you is a topography that you'll notice is spreading some rings off onto the sclera on the nasal side, while missing some of the cornea on the temporal side. So a visual axis capture means that our Placido may be leaning or tilted or moved over to the nasal aspect, shifted, I guess you could say. Well, this isn't so good, because the Wave software wants to build us a lens that's centered to the visible iris. I mean, when we look at the lens through the slit lamp, we don't want to see a lens that's slightly nasal or slightly temporal. We want to see a lens that's centered to the eye. And capturing our topographies this way may cause us to have slightly erroneous wave construction. And that kind of makes sense, because when you look at the visual axis capture, notice the blue on the nasal side. We really only get to green on the temporal side. If you look at this white axis line here, you notice that there's far more flat cornea here on the nasal side, where we don't quite get to that same curvature on the temporal. So our topography is shifted off nasally, and we're going to try to build a lens for this topography that isn't centered to the geometric axis of the eye. So let's do what the wave system would like to have, and that's a geometric capture. How do you achieve that? How do you best center the placido to the geometric center of the eye, laterally centered topography? Well, you're going to ask your patient to fixate 1, 2, or 3 rings over to the nasal aspect. So instead of looking right down the center, if you're capturing a right eye, I'm going to ask my patient to look 1, 2, or 3 rings in toward the nose. And you'll know when you've got it centered because the rings will appear balanced on both sides of the iris. The coverage will be ideal. Almost every patient has some angle alpha. Their fovea is temporally displaced, so it's a certain number of rings that they need to move over, but it could be different for every patient. You know, for one patient, it could be 1 ring, another, it could be 4 rings. Sometimes it's only a half a ring. It really depends, but what you want to do is ask the patient to look 1 or 2 rings over and then check whether that placido is best centered. And what we're looking for is when you look at the photokeratoscope image, you notice that the rings look like they're about equidistant from the border of the visible iris. So we have centered that placido photo. We've snapped our photo when the patient has in the right fixation to get that perfectly centered topography. Then when you look at the colorized map, you can see how accurate this is likely to be in terms of capturing the cornea laterally. And here we see the rate of flattening going toward the nasal and the temporal, and you see on the map down, pardon me, on the cross section down here, it's a kind of even power change or curvature change as you go from center to periphery. Now, another thing that you can do, and Medmont users can do, is the composite capture. And this is maybe adding another step in that you can take a topography looking right down the center ring, then you can have the patient looking 3 rings to the nasal side and you take a photo, then 3 rings to the temporal, you take a photo, have the patient look 3 rings up, then have the patient look 3 rings down. So essentially what you're doing is moving the data points so that they reflect off the peripheral cornea. And then all of those can be converted to a topography and merged in to create a larger view of the eye. From the experts at WAVE, they tell us that we need to explore this capture with the WAVE software a little bit more. The WAVE software wasn't built for specifically a composite type capture. So there may be some things we need to learn before we can really use this with great frequency. Personally, I feel very strongly in this capture. I love that I can get more data out toward the periphery, especially in a case like this. You notice that this patient has a lower lid that's relatively high in relationship to the cornea, and I can have the patient look up, and then I can take a photo and get some data points on that inferior cornea. Same thing with looking down. I can get some more data points up there at 12 o'clock. So this might be an important tool moving forward, but we'll wait for the WAVE team and their guidance on this one. The benefit, of course, of a composite is you get so much data. You know, in this case, we're getting 13 millimeters of data, and this will become very important related to scleral lenses. With Ortho-K, your standard Medmont map probably makes it out to about 11 millimeters already, certainly to the point where the lens touches down on the eye surface. But for a scleral, it would be nice to have a little bit more. So you've got some options. I think what we can agree, and certainly what we're guided by the WAVE team, is when you're building an Ortho-K lens, use the geometrically centered capture. Take multiple readings, at least 4, to make sure that you have reproducibility in your capture. Now, one other thing that we want to do in Medmont before we go to the WAVE software is to measure the visible iris diameter. And this is a very important capture that we need to take, because we're going to build a wave lens to within 0.2 to 0.5 millimeters of the visible iris. So it's a relatively large lens. And I'm imagining the reason why the wave experts found that going this big is helpful is because larger lenses are more stable. They are more likely to center. They're more likely to move less if they're stable and centered, and therefore they're more likely to be comfortable. So fitting a big lens is a benefit in any corneal GP. Make sure we take an accurate reading, because we are going to fit within a very short distance from the limbus. So this becomes an important measurement to do accurately, and that's white to white. Now, you've got your map. You are happy and satisfied that I got an accurate capture. I've got my visible, excuse me, I've got my visible iris diameter. Now I can send this topography through to the Wave software. So for the Medmont users, you simply click on your map, and then you're going to go to Home and over here to the linked applications, and you see your Wave link. It'll automatically just send all of those data points into the Wave software. So it makes it pretty easy for us to take all of those thousands and thousands of data points, send them into the Wave platform. Now, once it gets into the Wave, then the magic really begins. And this incredible platform gives you the ability to customize like few other softwares can. And if you're relatively new to lens construction, if corneal GPs are not something you feel particularly strongly about being able to build, and certainly a reverse geometry lens, the Wave software makes it pretty easy with a few clicks for you to construct one of the most advanced contact lenses available on the market today, with a landing that's specific and customized for each eye 360 degrees around. What makes me geek out a little bit is the ability to control these data points, which is brilliant. You can move those data points in or out to alter, of course, where you're going to get the vault, where you're going to get the landing, the depth of that point in the contact lens, making it closer to the eye, farther away from the eye, the specific micron elevation that you want for the back surface of that contact lens. And as an example here, we could alter this data point right here, this pink one, move it slightly in if I wanted to create a wider edge lift. If my patient were struggling with catching that edge to pop it out. If I was unhappy with the actual tip of the edge, I didn't feel like there was enough of a ski in edge lift, then I could bring this outer data point up to raise the elevation of the lens. If I want to alter the tear reservoir depth, if I want to move the tear reservoir in or out to alter the myopia control signal, I've got that ability with the Wave software. So it's an incredibly powerful platform. Now, once you've got your custom orthokeratology lens, once that Wave lens arrives in the office, you put it on eye and you're ready to dispense, then that's when, for me, the whole mystery of Ortho-K begins to unravel. Things become pretty clear. What I mean by that is an Ortho-K lens in the open eye is absolutely not predictive of what it's going to do in the closed eye. I mean, certainly I believe so confidently in this pattern that we are looking at, but we can't model lid force. We can't model gravity. We can't model whether a patient sleeps with a knuckle in their face. So all of these things might contribute to the lens not performing as we desire. So we really need this overnight wear to have a full understanding. I'm not very reliant on the fluorescein pattern. Of course, we're going to check it before dispensing, but I really want to see the post-treatment topography. Now, when that patient comes back, we're going to check the slit lamp signs, we're going to check vision, we're going to have an overall assessment of whether the patient was comfortable and had any issues with handling or dealing with the fluids and such. But then I want to hurry to the topographer, and not necessarily hurry, but I'm excited to get to the topographer because I'm going to learn what this lens actually did to the underlying epithelium. Now, when you take your map, is one topography good enough? Is this all we need to assess the outcome of Ortho-K? And hopefully you agree the answer is no. It's not just this one map that we need. A single topography post-treatment tells you what the cornea is now, but it doesn't tell you how the cornea has changed. We need a function called the subtractive or difference map to tell us that. So the subtractive map or difference map or comparison map is one of the most important tools that a corneal topographer provides in post-treatment analysis. The subtractive map is also useful in following a keratoconic patient over time, comparing point in time to see if there are changes. Is the keratoconus advancing, as an example? When we try to normalize a cornea after they've been in a contact lens for a long time, like Ortho-K, you can go week to week or month to month and check, do we see the cornea changing over time? If it appears to be the same between two visits, maybe the cornea has stopped changing. So the subtractive map tells us in axial interpretation, the refractive change, the treatment zone position, and the treatment zone size. When we switch the interpretation to a tangential map, it tells us the lens position in the closed eye environment. So do not, whatever you do, use one single topography. Use the subtractive map that draws together multiple topographies to interpret how the eye has changed. So what you see in the subtractive map is before Ortho-K, your baseline topography, after Ortho-K, and here on the right, your difference map. And what I'm seeing in the axial interpretation is the refractive change. When I click my cursor right on the center, tells me I have a 1.77 diopter myopic reduction. I can look at the blue treatment zone in position with the center of the topography, the visual axis, and see that this patient has a well-centered blue treatment zone. I can see the size of the treatment zone as well, and I can relate that to the quality of vision the patient has. Then we switch over to the tangential map and we look at this red ring. So you're essentially ignoring this action in the center like you do on the axial map. You look at the center blue. In the tangential, you ignore what's in the middle and you look what's pericentral to that. And that's this red ring where you have your suction force underneath the lens, the fluid pulling on the epithelium. The next zone out in an Ortho-K lens is the landing, and that creates this blue area of flattening. So the tangential map tells us pretty definitively where the lens is centered in the closed eye environment. So what we've seen here is an example of the perfect bullseye topography, where the blue treatment zone centered to the pupil and visual axis, the tangential map showing you a red ring, maybe similarly also a blue ring centered to the pupil or the visual axis. Now, a question for you is, this case that you just evaluated, we've agreed that it's a good Ortho-K outcome, it's a bullseye, but is it a good myopia control outcome? Well, what would we look at to determine if we have an ideal topographical shape to slow down the eye growth? Well, let's go back to the axial subtractive map. That's the key for understanding whether we've created a ideal treatment for the kids. we're going to determine the refractive change by clicking our cursor right on the center of the topography and assessing that power along the right-hand side in your Medmont. So it's right here when you click your cursor right on the center of the map. And so we'll blow that up and we got 1.77 diopters RX change. Now we know the central shift, what's being presented to the fovea. Now we want to understand the defocus that we've created in the periphery. So let's put our attention on that box down below. That's the powers within the pupil across this white line here. And you can see that power shift between the foveal change, or what would be presented to the fovea, and what's presented through the peripheral part of that central zone within the pupil, essentially. Now, to understand the myopia control signal, the defocus, what we call at Pacific University, the myopia defocus dosage, we want to look at that central power change, 1.77 diopters. Then we want to click our cursor on the pupil border and determine what power are we getting out there on the periphery. What's making it through the margin of the pupil right at the border? And that's minus 0.11. So we go from, at the foveal center, 1.7, on the visual axis in the center of our topography, we go from minus 177 to the borders of the pupil, 0.11, and a difference between the two of them of 1.66 diopters. What does this mean? Well, this is a really important value because this tells you how much defocus, how much signal, how much myopia controlling effect have you created for this patient. I would say this is a mediocre outcome. I haven't pushed a lot of plus into this eye. So before I've even started with Orthok, I mean, I'm with this patient's a week into wear, I've got an idea of what kind of effect that this lens is creating. And if there's any increase in myopia or axial growth over the short term, I know I need to ramp up that signal. You might even consider ramping up the signal now, getting north of 2 diopters of myopia defocus dosage. Another thing that we can look at post-treatment is the spherical aberration. And if you compare pre versus post, we can get an idea of how much we've changed the spherical aberration in the positive direction. And Orthok is almost always going to move the eye toward positive spherical aberration, which is good because the research has been pretty clear. The higher the spherical aberration, the better the myopia control. What we don't have a good sense of today is what is the magnitude of spherical aberration that we want for most eyes. The thinking seems to point us in the direction of an increase of 0.8 appears to be a healthy number, but again, we have to do more research on this one. But stay tuned because spherical aberration might be that quick and dirty value that you look at. Compare before Orthok to after Orthok. The difference between them will tell you how much myopia control signal that we're pushing into that young eye. Now, what are some of the other outcomes that we have in orthokeratology treatment? And one of them is this, where you see the blue treatment zone decentered high in relationship to the pupil. So I put that dotted line around where the pupil border is, and you notice how the blue treatment area on the axial map is high. We switch over to the tangential map. We always use those two maps in combination with each other. Sometimes one map is a little bit hard to interpret, especially after one night in wear. After more days, it generally becomes clearer, but at that one-day visit, you might be confused by one map, and so it's nice to have both guiding your decision-making. Now here you can see the red ring highlighted in relationship to the pupil. So that dotted line again is the pupil. You notice the red ring is inside the pupil by about 1 millimeter. It's above the pupil by about 1 millimeter. So this lens is riding on the right eye up and out. It's kind of loose, a loose fitting. So this is what you call the smiley face outcome. And this is where the alignment of the lens is on the loose side, or it might have been a perfect wave construction, but you just have this wicked strong lid force that's pulling the lens up when the patient's sleeping. We may need to neutralize that tension force that's being created by tightening up the lens, causing it to come down slightly. Now, another finding that we see in Ortho-K, the topographically, is this one, where you have the opposite of the smiley face. You've got that upside down the smile, the frown, basically. And if you look at the blue treatment zone in relationship to the pupil, you'll notice how inferior it is relative to the black pupil that we've highlighted with the white. So this one, opposite completely to your smiley face outcome and fixed opposite to the smiley face. When we look at the tangential map, you see that red ring low in relationship to the pupil margin. Notice how the red ring is more than 1 millimeter inside the pupil. It's just below down here. You could look at the blue as well. The alignment zone of the lens is past the border of the pupil and it's well below somewhere down here. So this lens is definitely riding low, and this is what you call your frowny face outcome, where the lens is on the tight side and it wants to ride low. So loosening up the lens, loosening up the alignment zone is the way to resolve the frowny face outcome. Sometimes diameter can be off, so you might double check diameter just while you're making your modifications. Make sure that it wasn't a lens too big or even possibly too small. Usually a lens too big is tighter, and that can cause that inferior displacement. Now, one that we don't see with great frequency is this one, and this is where you see some apical steepening on the map. So instead of the blue flattening, you've got this increasing curvature. We have actually made the myopia worse. Generally, the patient doesn't manifest a lot of myopia from this one. Usually it's induced astigmatism that you find. So patients with what's called the central island usually have poor quality of vision in the AM, but it wears off fairly quickly. What you'll see is that the blue area, we might call a treatment zone, but it's not really, because we've got the steepening in the center, is normally on the low side when you have a central island. And you can see how the blue-green border is about right here, heading north, but heading south, it's a good millimeter below the pupil margin. When we switch over to a tangential map, notice that red ring in relationship to the pupil border, definitely riding on the low side. For all topography users, and certainly Medmont users, make sure that you're adjusting these scales here. You'll notice that I have this marked as a 2 diopter scale, meaning I'm showing the maximum change as +2, the minimum change -2. That really gives you a lot of definition. It really brings out the reds and the blues. On the axial map, it's helpful to be able to understand the full range of power, especially within the pupil. So, and having this scale range specific for the refractive change on this particular eye is helpful. So what I do is I have a 2, 3, 4, 5, 6, 7, 8 diopter scale, and then maybe one 10 diopter scale. And that way, if I'm doing a -2 myope, I set the scale to 2 diopters, so I can see the full range of power, the full detail on that particular patient. If it's a higher myope, like a -8 Ortho-K effect, then I might adjust the scale up to match the treatment we're creating. So that can be a helpful hint when you're assessing these post-treatment outcomes. Set the scale specific for the refractive change that you're using. Now, a central island is normally a lens too far off the eye. It has excessive apical clearance, and it's creating a central suction force pulling the epithelium up in the center. It's often associated with a tight alignment, so the overall fitting of the lens is too much squeeze, too much sagittal depth. So we need to drop the sagittal depth, loosen the alignment, and that will typically be resolution. Also look at diameter, kind of like in the frowny face. A big lens might fit a little tight in the periphery. So possibly we built our lens too big for this particular eye. So these topographical outcomes, remember, subtractive outcomes, really guide what our assessment is of orthokeratology. Do we need modifications? Can we make improvements? We need to use the subtractive map. Once we get that, then you can understand, have I created optimal myopia control for this patient? What I mean by that is, if you look at the smiley face and the frowny face, they create central flattening. So they create myopic reduction. They usually provide the patient with very good vision in the AM. But in the PM, that smile in the smiley face or that frown in the frowny face that's inside the pupil can create increased coma and higher order aberrations. So the patient's quality of vision may not be as good. They may lose their effect fairly quickly over the course of the day. So understanding that we've created the ideal topographical outcome can help guide us to provide the patient with the best possible visual and physiologic outcome. Let's talk just for a second about wave lenses building a scleral lens. And I understand from the wave team, the vast majority of wave lenses are Orthok. Makes sense. It's kind of a dominant contact lens today. It's certainly at academic conferences, the vast majority are very much myopia control related and Orthok related. But sclerals, of course, is that other hot topic in specialty contact lenses. With the wave system, you can build a scleral lens. With any scleral lens, the whole story is sagittal depth. I mean, certainly there are other factors like appropriate landing, the power, creating the right, the edge to surface relationship, vaulting through the limbus. I mean, there's lots to a scleral lens, but rule number one is build the correct sagittal depth for the height of eye that you're fitting. And you can see in all of these eyes, they have very different sagittal depths. Our normalized versus keratoconic versus pellucid versus keratoglobus. They're going to need completely different heights. So could you use the topographer to help you along this path when the Medmont is a corneal topographer, not a corneal scleral topographer? Well, the Medmont does an awesome job of measuring corneal sagittal depth. And that's half the story in building the depth of eye that you need. The second part of the story is to determine the angle that begins to form out there at 10 millimeters and runs right past the limbus and sclera. So if we can get information on the peripheral cornea, then we could predict the height of lens that we may need in the center, the sagittal depth of lens that we'll require. So the Medmont allows you to estimate the height. There's an attribute called the EH, estimated height attribute. And you can set a chord diameter, in this case 15 millimeters, and understand at a number of angles what the height of the eye would be estimated to be. And that's based on the corneal sagittal depth and the angle that forms out here. So this is helpful because that can get us to a more accurate depth of scleral lens. Now we take that estimation, that assessment, that measurement at 3 different angles at basically 0, 180 and 3210 and 150, 330. The idea being we want a bit of a sampling so we get an idea of how much sag may exist across this eye. It can be very challenging, as you can imagine, to get a vertical meridian measure on some of our very deep set eyes. So I primarily concentrate on the horizontal meridian, or close to where I know we're going to stretch that topography data out. Now with WAVE, it can do exactly the same thing. We can take the sagittal depth measured by the Medmont. We can take that peripheral corneal angle. In the case of the WAVE, it assumes to start that every eye has a 37-degree angle. And this is brilliant because the average shape of the scleral surface is very close to 37 degrees. So in other words, when you map, when you do, sorry, I shouldn't say map, when you take ocular coherence tomography on a large cohort of both normal eyes and keratoconic eyes, they come up pretty close to a 37-degree angle. So this is a really good starting point with the WAVE software when you want to build a scleral lens. So again, let's take our map that we're comfortable with. In this case, you might default to what your WAVE expert is telling you to use. I believe that a composite map would make the most sense because we're getting so much data out there, but I'll submit to the experts with the WAVE team and what they believe is the best for a scleral fit. Now we're going to go up to that WAVE link in Medmont, just send that map right into the software. And the last thing that we might want to do before we build any lens is check the visible iris diameter. And the recommended WAVE scleral lens is visible iris diameter plus 4 millimeters. So on an 11/8 millimeter eye, we would want to start out with a default of, around 14.8 millimeters as, 15.8 millimeters as kind of an optimal starting point for this patient. So VID plus 4 millimeters is a good starting point. Now, once the lens is within WAVE, once you have your construction, then you have that same ability to customize within the software, using these control points to change how that lens to surface relationship is constructed. And this is so powerful in a scleral lens because we're trying to optimize quite a few things. We need to get that alignment with the conjunctival surface optimized. We want the limbal vault. We want to protect the limbal stem cells. Then we want to create vault over the entire cornea, especially if it's in a diseased eye. We want to protect the diseased tissue. So being able to make those control points change that tear layer profile, one of the very valuable tools of WAVE. And I think what makes this software so special is that ability to customize both the depth of those points, but the position of those control points. So why WAVE? And I'm sure almost everybody here is a WAVE user, but if there's anybody here that's a neophyte to WAVE, why would you want to take this third-party platform? And the reason is hopefully pretty clear in this talk, that what WAVE allows you to do is a level of customization that few other softwares can make possible. So rather than taking an assumed eye from maybe K readings, you're taking all of those thousands of data points, importing it into the WAVE software, and then you're able to build this highly customized lens. So it is pretty cool stuff. And what moved me was that if I don't have a lot of familiarity with wave, there's a way to build a lens quite simply and just start with a default product in the system that gets me started. And then I can rely on the experts from that point forward if I'm feeling that there's some manipulation to landing needed or edge lift, or if there's some change that we need to make. And that's a very important thing, of course, is the technical team becomes the most valuable part of a system like this, where we have a complex software platform and we're relatively new to it, and having that expertise to go with, of course, uber valuable. Now, why the Medmont? Why use the Medmont Topographer with wave? Certainly the accuracy of the Medmont is sort of hard to argue. There's been so much data on using this instrument with specialty contact lens. It's been validated a bunch of different ways. Other topographers even use the Medmont to validate their own accuracy. So I think we can say the Medmont is a pretty good tool for building specialty lenses. Another reason why it might be a choice is the options that you have for imaging. You have your placido cone for measuring the shape of the eye, but you also have these 3 illumination points on either side that allow you to illuminate the anterior surface a number of different ways. As an example, you can do fluorescein images of your lenses. That's kind of helpful, especially working with your wave consultant, because you could take that image and export it to the wave team, and they can assess the pattern with you. You also have the ability to take videos of the lens and again, to share that with the wave team, so that's valuable. You can do white light anterior segment assessment. You can do photography very specific to the lid margin and the lashes, if this is a dry eye workup, as an example. All of your scleral imaging is possible because you've got this humongous field of view with the system. You can do non-invasive tear film breakup time testing. So you basically just follow what the tear, or have the instrument follow the tear film over time to see what areas are breaking up, how broad it is, the magnitude of that breakup, and the surface area of the breakup. So non-invasively, which is the way to measure tear film breakup time today. We can do myopography because there's infrared light as an option, one of those 3 different illumination sources. Measure tear meniscus height. So this, you can tell, this becomes a dry eye tool, not just a contact lens tool. Then there's grading scales that help you to build a dry eye report. So this tool becomes so much more than just a corneal topographer. For our kids in myopia control, you have a very powerful imaging device that can be used for a whole range of different stuff. And I do work as a consultant for Medmont as an advisor, but we at the school love our Meridia. It's the tool we use for virtually everything in terms of imaging, and certainly related to corneal topography. That's the tool that we favor, even though we have every topographer virtually. So in review, what we want to make sure that we do to partner the best way possible with wave is to ensure that we've got good coverage. Get that patient to open up as wide as possible. When you look at that reflection, those rings reflecting off the eye surface, do we see any breakups? Are there distortions or warping of those rings? Let's get our patient to blink regularly. If that doesn't do it, put in artificial tear, try to smooth over that reflection. Take a geometric centered topography for your Ortho-K lenses in wave. Take multiple readings. So take minimum of 4 maps. Look for reproducibility. Throw out the bad maps, keep the good ones, choose the best one, send that one into wave. Figure out how to use that subtractive map for your post-orthokeratology analysis. Figure out how to do an axial map and a tangential map. And then consider using the topographer with Wave together to build a scleral lens. The platform can build so many lenses, not just Ortho-K, single vision corneal GPs, multifocal GPs, and of course, scleral. So we really have a very valuable tool that goes so much beyond its use in just orthokeratology.